My name is Ioannis Parodis, and I'm a rheumatologist at the Karolinska University Hospital in Sweden. I thank the committee for giving me this opportunity to present our data on BLyS and April in lupus nephritis. We have no disclosures. The aim of our study was to assess serum levels of BLyS and April in patients with lupus nephritis, to understand how these levels are affected by immunosuppression, and to investigate BLyS and April as potential biomarkers for lupus nephritis. Lupus nephritis affects up to 50% of all patients with SLE and is a major cause of morbidity. Despite better understanding of autoimmunity in SLE, we still lack reliable biomarkers for lupus nephritis. The B-Lymphocyte has a pivotal role in the pathogenesis of SLE and autoantibody production. BLyS is a ligand belonging to the TNF ligand superfamily. It is also known as BAF. It has an important role in the activation and differentiation of the B cell, as well as in the maintenance of activated B cells. BLyS is overexpressed in patients with SLE and rheumatoid arthritis. April is another member of the TNF ligand superfamily. Its role is less well defined, but it has been shown to be involved in the induction and maintenance of B and T cell responses. BLyS often appears as a homotrimer. It is expressed as a transmembrane protein on various cell types, including the dendritic cell, the monocyte, the macrophage, and the neutrophil. The transmembrane form can be cleaved from the membrane, generating a soluble fragment. Sometimes it appears as a heterotrimer together with April. BLyS and April have two receptors in common on the surface of the B cells, BCMA and TACI. BLyS additionally binds to BR3. Belimumab has recently been approved as a treatment for SLE. It binds to soluble BLyS, preventing it from binding to its receptors, leading the B cell to apoptosis, thus reducing the production of autoantibodies. 64 patients with biopsy-proven active lupus nephritis and the same number of gender and age-matched controls were included in our study. The patients were treated with corticosteroids combined with cyclophosphamide, mycophenolate mofetil, or rituximab, and they underwent a second renal biopsy after completed induction therapy. Serum was collected before and after induction treatment for the patients and at recruitment for the controls. The serum levels of BLyS and April were estimated by ELISA, and the renal biopsies were assessed according to the ISNRPS classification system, as well as the activity and chronicity index. 86% of the patients were females, and the population was to its biggest part Caucasian. The mean age of the patients was 34 years. The time between the two biopsies varied depending on the duration of the induction therapy, and the mean proteinuria at baseline was 2.2 grams per day. At baseline, 52 patients had proliferative lupus nephritis and 12 patients had membranous nephritis. At follow-up, a large fraction of patients showed improvement to class 1 or 2, while the number of patients with membranous nephritis had almost doubled. Reflecting the changes in class, the median activity index at baseline and follow-up was 5 and 2 respectively. We defined clinical response in line with the ACR recommendations as at least 50% reduction in proteinuria, normal or improved renal function, and inactive urinary sediment. For complete response, the proteinuria at follow-up should be less than 0.2 gram per day, whereas for partial response, it should be between 0.2 and 2 grams per day. In both cases, the proteinuria had to be reduced by at least 50%, the GFR had to be improved or normal, and the urinary sediment had to be inactive. We defined histopathological response as at least 50% improvement in the activity index for partial response, and additionally demanded a lack of signs for active inflammation in the follow-up biopsy for complete response. Looking at the results, BLyS levels were significantly higher in lupus nephritis patients than in controls, but they remained unchanged after induction treatment. APRIL levels were significantly higher in patients compared to controls at baseline, but not at follow-up. This is consistent with a significant reduction of APRIL levels at follow-up. This decrease seemed to be more prominent in patients who received cyclophosphamide and was not statistically significant in the other groups. However, an obvious trend was seen, and the lack of significant change is likely due to the low number of patients in these groups. When we analyzed all cases together, BLyS levels remained unchanged, and APRIL levels decreased significantly in both responding and non-responding patients by both clinical and histopathological response. When we specifically looked at the patient group with proliferative nephritis, the decrease of APRIL in non-responding patients was not statistically significant. APRIL has recently been suggested as a candidate biomarker for lupus nephritis, as it seemed to correlate with renal disease activity, and high levels were shown to predict treatment failure. We observed decreased levels of APRIL after immunosuppression, and this decrease is not significant in non-responding patients with proliferative nephritis, implying that APRIL is of importance in proliferative lupus nephritis. These findings support Klimczak and Pom and co-workers' suggestions. However, after further analysis of our data, we do not find any correlation between APRIL and renal disease activity, and our ROC curve analysis does not reveal any predictive power. Thus, we do not find APRIL to be a good biomarker for lupus nephritis. On the other hand, the ROC curve for BLyS by treatment response revealed potential predictive power, and further analysis showed that low levels of BLyS predicted response to treatment with high positive predictive values for both clinical and histopathological response. It is known that BLyS correlates with SLE disease activity. We observe that BLyS is overexpressed in patients with lupus nephritis compared to controls, but does not correlate with renal disease activity. The BLyS levels remain unchanged after immunosuppressive treatment, suggesting that conventional treatments do not affect BLyS-producing cells. Taking together the latter with our observation that low levels of BLyS predicted response to treatment, we speculate that neutralization of BLyS levels might result in better treatment responses, especially in patients with high BLyS levels at baseline. To summarize, BLyS and APRIL are affected differently by immunosuppression. We suggest low levels of BLyS as a predictor of response, and our data imply that BLyS-producing cells are not affected by conventional immunosuppressive treatments. Thus, we speculate that agents targeting BLyS as an add-on to conventional immunosuppressive therapies might result in better treatment responses. Further studies are needed in order to understand the mechanisms behind differences in BLyS levels in patients with lupus nephritis, and of course to confirm these findings. Thank you very much.
Thank you for that elegant presentation. We have time for one quick question and one quick answer. I'll ask you the quick question then. Have you had the opportunity to follow any of the patients after induction to see what happens to the levels of BLyS or APRIL after they responded? And would it be predictive of, a relapse?
No, we have not done this.
I have another question. Have you checked for urinary losses of APRIL and BLIS, especially in those with class 5?
You said if we have
Urinary losses.
urinary?
Losses.
No.
No. Thank you.